So we invite you for the next presentation, which is idiopathic intracranial hypertension.
So good morning everybody, and sorry I was just a little bit my topic is intracranial hypertension. So it was earlier known as BIH or pseudotumor cerebri, or there are other hydrops, meningocele hydrops. There were earlier names when it was discovered in 1800 something. So what is intracranial hypertension? It is a syndrome of increased intracranial pressure, and it can be primary. Primary means when we used to say BIH or benign intracranial hypertension, but nowadays benign is not used because many a time these patients progress to vision loss. So it is primary when there is no reason, and secondary when there are so many reasons to this. And what are the reasons? We would just look into it if the presentation goes by. And importantly, brain venography imaging have shown that the most patients with IIH may have structural abnormalities which were earlier considered to be IIH, primary IIH, of the cerebral venous sinus system. And stenosis of the transverse venous sinus, since IIH is often associated with venous sinus stenosis. Since the disease is often refractory, you start with Dimox and other drugs, and it is just continuously the papilledema is there, and gradually we know that the optic atrophy is now pursuing. So multimodal treatment are often employed, including the weight loss programs, carbonic anhydrase treatment, or therapeutic lumbar puncture and LP shunts. So despite these strategies, 38 to 45% of IH patients experience eventually symptoms of worsening or recurrence within 6 to 10 years. So CSF, it is a clear plasma-like fluid secreted by choroidal plexus and within the lateral third and fourth ventricle, and secretion of CSF equals its removal. That is how the ICP is maintained in the brain, and it is the quantity of it is 152 to 70 milliliters. So this is how the drainage of CSF goes through. It is there. So this is the choroid plexus in the body of the lateral ventricle. From there it goes to your intraventricular phenomena to your third ventricle. From there it goes to through cerebral aqueduct into the fourth ventricle, and from there fourth ventricle from your foramina of Luschka and Magendie to the cisterna magna and CP angle cistern. This is how, and from there the CP angle cistern, it goes into the spinal cord, again it goes up into the brain, and this is how it becomes circulated. So dural venous sinuses, these are the sinuses, they are lying between, these are the channels located intracranially between the two layers of the dura. That is the periosteal layer and the meningeal layer. As you can see over here, this is the periosteal layer and the meningeal layer. This is the periosteal layer and this is the meningeal layer, and this is the cross section of the straight sinus which is lying in between both the layers. And these are the arachnoid granulations, which are just what is they are doing, they are draining the CSF into the venous channel. Venous channel, that means your straight sinus, or you can say into the superior sagittal sinus. From there it is through your transverse sagittal sinus, through sigmoid sinus, and from there it is going into the inferior vena cava, internal jugular vein, and through the superior vena cava it is going into the heart again, and now it is again circulated. And this is a diagram showing how this raised ICP is the etiology of it and how this is causing the symptomatology. This is there can be an increased CSF production at the choroid plexus. There can be reduced drainage of CSF across arachnoid granulations, and this reduced drainage may be because of the arachnoiditis or tubercular meningitis or any meningitis, leptomeningitis, that is causing the decreased drainage through the arachnoid granulation. And there can be, this all would be leading to your what? Increased venous sinus pressure. This increased venous sinus pressure can be because of this, the stenosis of these sinuses, and mainly the transverse venous sinus. So just straight away I am going to the case. A 50-year-old female presented with complaint of headache, tinnitus, decreased vision in both eyes for last 8 to 9 months, best corrected visual acuity, both eyes 612. This was the fundus picture showing bilateral papilledema, and this was the constriction of the field, generalized constriction. This is your blue line showing that your RNFL on RNFL showing the optic disc edema, and this is the MRI of the case. Definitely you can see over here, this is a T2 weightage image, and over here you can see the partial empty sella or the empty sella, and over here you can see the perioptic sheets, they are dilated, again a T2 weighted image. And this is the MRV. Now this is, you can see over here, this is the MRV of this case. This is the superior sagittal sinus, this is the confluence of the sinus, and from here this is the transverse sinus, and this is the sigmoid sinus. So definitely you can finding it over here, focal definite stenosis over here, and this is the left transverse sinus which is hypoplastic. So this is hypoplastic, that means the whole of the drainage from this system, and over here this is a focal stenosis. at the junction of the sigmoid sinus and the transverse sinus. So a diagnosis of intracranial hypertension was made. Patient was started on medical medications like acetazolamide, furosemide, oral anticoagulant. Headache was persisting and disturbing. Vision was 624. That has decreased from 612 to 624. Patient was having continuous visual deterioration. So DSA was thought of, and urgent stenting was thought of because of this. This is a DSA you can see over here. This is the transverse sinus stenosis on DSA definite, and there was a pressure gradient between the distal part and the your proximal part. It was more than 10 millimeter of mercury, and you can see over here. So this is how it was planned. You can see this is the balloon which was put into the transverse sinus, and after ballooning it, the stent was put. You can see over here, this is a meshed stent over there. So post stenting, you can see very well over here. This is now patent, the transverse sinus. The pressure gradient came down to be less than 10 millimeter of mercury. This was the pre-op picture, and this is the, on the right side is your post-op picture. This is how that papilledema resolved, but that your optic atrophy has ensued, and this is how that your RNFL decreased. Second case, 35-year-old female. She was a case, she came to us 6 years back, and she was having tinnitus, headache, and transient obscuration of vision. At that time, she was diagnosed as a case of primary IIH. She was put on acetazolamide, furosemide, and she went away to her native place. But after 6 years, she came to us. That means last December. She came to us. Then she was telling that okay, she was having a lumbar peritoneal shunt that was done in Bareilly by a neurosurgeon, but in spite of that, she was having transient obscuration of vision, and she was definitely having a tinnitus, which was very bothersome. That is the reason she came to us. She was off and on Diamox and your furosemide, and reappearance of papilledema was there when we saw her last year, and she was having this blurring of vision. This was her field, and this was her RNFL over here. You can see definitely it was raised. This was her MRV, a contrast enhanced MRV, and it was showing a definite focal stenosis. This was that your DSA, which was again confirming. This is the wire, the stent wire. You can see the guiding wire, sorry. And this was the pressure, the 42 millimeter in the proximal part and 10 millimeter in the distal part. That means it was 32 millimeter difference between both of these. So again, this is the mash of the stent, you can see, and this is pre and this is post. And definitely the very next day, that means within 10 to 12 hours, she was saying, okay, my tinnitus has gone. Gradually, she was improving with a transient obscuration of vision. So this is how that case. So this is our study, papilledema, revisiting after sinus angioplasty of chronic cerebral venous sinus thrombosis. And this is another study that was published in 2023 in Frontiers, transverse venous sinus stenting, reversing your medically refractory IIH or the secondary IIH, you can say. So what is a medical refractory? It is a progressive visual field loss on maximum, drug therapy, persisting papilledema on maximum, drug therapy, recurrent papilledema on weaning of drug therapy, or intolerance to your maximal drug therapy. So these are the adults which with medical refractory disease associated with significant transverse venous sinus stenosis. Such patients, historically, they progress to CSF diversion with a shunt, or fenestration can be done, but maybe that your stenting can be a viable option in these cases if all the symptomatology is persisting. So I'm not going into these details. All patients with IIH should undergo MRI with contrast, definitely, and MRV with contrast. That is very much important, because without contrast, many a times these patients can be missed. And when medical treatment fails, visual loss is rapid, then lumbo LP shunt or optic nerve fenestration may be considered prior to your stenting. Stenting means that first you have to do the DSA. I think that is enough. Thank you.
Thank you, Dr. Vikas. We would request all the speakers to kindly adhere to the time limits. So, any questions or discussions? Okay. Thank you, Dr. Vikas.